Good afternoon, everyone. Thank you all for joining us today for the COVID-19 Pediatric Update. My name is McKenna Byerly. I am with the Continuing Education Department at Norton. So a few logistics that we'll go over before we get started. Participants will receive a link following the program for an evaluation. So we'll have that displayed on the screen at the end of the program. We'll also send out an email if you are registered. And we will also enter that evaluation link in the chat upon the program completion. We plan to post this, we are recording it, so we plan to post this online within a day or so at nortoncme.com. And we will stop around 12:45 with the presentation, and we will address any questions from the audience. So we just encourage you, any questions that you have, please enter those into the Q&A section. You can find that at the bottom of your screen. We want to avoid putting things in the chat so that we don't miss any questions from you. So please enter those in the Q&A section. And if you have any questions regarding CME, you can put those over in the chat, or you can email us at cme@nortonhealthcare.org. And so I'd like to get started today by introducing our speakers. So first, I'd like to introduce Dr. Kristina Bryant. Dr. Bryant joined the University of Louisville School of Medicine faculty in 2000 and is currently a professor of pediatrics in the Division of Pediatric Infectious Diseases. She is also a medical director for the Pediatric Infection Prevention and Control at Norton Healthcare. She's the immediate past president of the Pediatric Infectious Diseases Society, the world's largest organization of professionals dedicated to the treatment, control, and eradication of infectious diseases affecting children. She recently completed a term of service on the Healthcare Infection Control Practices Advisory Committee, or HICPAC, a federal advisory committee that provides advice and guidance from the CDC regarding strategies for surveillance and prevention and control of healthcare-associated infections in the United States healthcare facilities. She has a relevant relationship as an investigator on clinical trials funder. I'm going to start over. She has a relevant relationship as an investigator on clinical trials funded by Pfizer, Gilead, and Enanta to disclose, and all relevant financial relationships have been successfully mitigated. And our second speaker today is Dr. Gary Marshall. He received his medical degree from the Vanderbilt University, where he also completed his pediatric residency. Dr. Marshall completed his fellowship in infectious diseases at the Children's Hospital of Philadelphia. In 1989, he joined the University of Louisville Department of Pediatrics, where he is now the professor of pediatrics and the chief of the Division Pediatrics Infectious Diseases. Under Dr. Marshall's leadership, the Division of Pediatric Infectious Diseases, he has repeatedly been recognized for excellence in teaching and patient care. Dr. Marshall is a member of numerous academic societies and has earned several national leadership positions. He is credited with over 190 publications and is best known for his work in vaccine development, advocacy, and education. Dr. Marshall is the author of the Vaccine Handbook, a practical guide for clinicians, also known as the Purple Book, and it is now in its 9th edition. Dr. Marshall has the following relevant relationships to disclose. He is a consultant to Pfizer, an honoraria for service on Pfizer advisory boards, research contracts with Pfizer, and is a principal investigator on clinical trials sponsored by Pfizer, and all relevant relationships have been successfully mitigated. And so with that, I would like to turn the program over to Dr. Bryant to get started. Thank you so much for being here with us today, Dr. Bryant. We're looking forward to it.
McKenna, thank you both for that very nice introduction and for the opportunity to do this. I will say that I have missed people. For a while, we were chatting very frequently, and it's been a while since we've all gotten together. So thank you to the audience for joining in, and let's get started. All right, you've heard my disclosures. I want to start out by talking about the impact of the pandemic on children in the US, right? The impact is so much more than just a case count of SARS-CoV-2 infections. One of you submitted a question in advance about how many children have lost a primary caregiver. Well, more than 141,000 and counting. There's a really interesting website. I've placed the link at the bottom where you can see regular real-time updates about the numbers in the US and globally who've lost a primary caregiver or primary and secondary caregivers. If we look globally, this number is more than 3.4 million and climbing every day. I don't have to tell this group about delays in childhood immunization and preventive care, interrupted learning, and increases in a whole bunch of negative health outcomes, emergency department visits for mental health issues, hospital admissions for eating disorders, suicide attempts in adolescents, increases in obesity, increase in type 2 diabetes diagnoses. I could have made a whole second slide addressing adverse health outcomes. We do need to talk about the number of cases of COVID-19 though. When you see this 6.3 million cases and counting, know that this really isn't the total number of children who've been infected, just the total number of children who've been tested and reported. This is likely an underestimate because children are less likely to be tested, maybe because they often have mild or asymptomatic disease, but not always. There have been more than 65,000 hospital admissions of children with COVID-19, more than 5,200 cases of multisystem inflammatory syndrome, which is a post-inflammatory or post-infectious inflammatory condition that may be life-threatening, and provisional deaths due to COVID-19 in children now top 650. If we just focus on children 5 to 11, there have been nearly 2 million cases, more than 8,300 hospitalizations, and MIS-C is actually most frequent in this age group. I wonder if it would surprise any of you to know that over the last year, COVID-19 is the 8th leading cause of death in children 5 to 11 years of age. This was a startling statistic. Well, what about here at Norton Healthcare? Summarized on this slide are our COVID-19 test, and in the red, the number of positives by month. You can see that August was our peak month. Test and positive cases have been declining since then, fortunately, but COVID's not gone. This is our pediatric hospitalizations just over the last year by month. Hospitalizations peaked in September. As of this morning, we had 5 patients admitted, 1 in the ICU. We had a question about deaths. It's submitted from the audience. If you look at the AAP data tracker, it reports there have been 6 deaths in Kentucky children. I am aware of 3 at Norton Children's, all in adolescents. If we look across the river, 21 deaths in Indiana children. I'm just going to close with good news while I stop sharing and let Dr. Marshall bring up his slides. COVID-19 is now a vaccine preventable disease in all children 5 and above. This is incredibly exciting. We now have the opportunity to prevent a lot of suffering from COVID-19. All right, Dr. Marshall, it's all yours.
Okay, Chris, can you verify that you can see my slide?
Yes.
Okay, great. So I just want to reiterate my potential conflicts of interest, which are listed here on the slide. I also want to say that we'll be referring to the vaccine as Pfizer because the trade name is too hard to pronounce. And participants in this program, at the end of the program, should be able to understand the key findings from the pivotal clinical trials that were done in kids, to explain the rationale for COVID vaccination in children, and to answer parents' questions about the vaccine. So please write down your questions and we'll try to address those at the end of the program. So as if what Chris told you is not enough justification for a vaccination program in children, I want to emphasize one other really important piece of this. So this is the daily case average in the United States throughout the pandemic. And you know that we've had these waves, and the waves can be characterized by the variants that predominated during those waves. So in the very beginning, we had what is called G614, and I'll tell you about that in a second. Then the holidays last year, we had the Alpha wave, and then most recently, the Delta wave. So what do I mean by G614? And this is what I find to be so interesting about this virus. It is capable of evolving very quickly. So in the ancestral strain that arose in Wuhan, China, there was an aspartate at position 614 in the spike protein. However, the strain that predominated in Europe early on and the one that made it to the United States had a glycine at position 614. But what I want you to appreciate is look at how quickly, in just 2 months' time, all infections in the world transitioned from the D614 to the G614. And this was a selection that allowed for the virus to bind to cells more efficiently. So, it's all about the spike protein, right? So this is what the spike protein looks like in its closed and in its open configuration. And the business end of this molecule is right here in this part of the top that flips open and binds to the ACE2 receptor. Well, what happened between the D614 and the G614? One amino acid changed the proportion of S protein molecules on the surface of the virus that were in the open configuration. And that is what led to the increase in infectivity and the survival of G14 as the predominant world strain. Just to emphasize this point, you know that the spike protein binds to the ACE2 receptor. Well, the strains that emerged since Wuhan have had higher affinity. They've been selected for better binding to the ACE2 molecule. And they've also now begun to evolve under the immunological pressure of a population that is basically partially immune because of natural infection. So the newest strains have glycans added to the molecule, which allow it to evade host antibodies. And they also have substitutions in the stalk region, which increase the flexibility of the spike protein so that when the virus is approaching cells looking for its cognate receptor, it's able to find those receptors more easily because the S protein can pivot back and forth. Most recently, we've had the Delta agent, which has evolved its own set of characteristics. So this virus can infect cells more readily. Here you see data on infectivity of human lung cells in the wild type versus the Delta. It also is capable of evading the host immune response. And so this is convalescent serum. I don't know if you can see my pointer, but I'm pointing anyway, where convalescent serum was put up against the original strain and the alpha and the beta, the delta. And you can see here that the ability of convalescent serum to neutralize the delta agent was lower. And then biologically, this virus behaves differently in that when it infects cells, it's more capable of forming syncytia than the wild type strain. My point is that this virus ain't stupid, and it is going to do whatever it can to perpetuate itself. And so when the virus infects the pool of human beings who are either naive to the virus or may be partially immune or are immunocompromised and can't clear the virus, giving it a heyday in terms of its evolution, we start with a red virus and we come out with a purple virus. The other two important points about this, and again, I'm trying to build the justification for you for childhood vaccination, is that within a few years, the models are predicting that COVID-19 will become an endemic disease of children, so that every year we're going to see COVID cases that will probably be seasonal, and they will be occurring in children, much like what we see with paraflu or adenovirus or RSV. So, and the other thing I want to point out is that natural immunity is not perfect. And so there are models that look at the decay of antibody that show within 16 months of natural infection, half of people are no longer immune to reinfection. And again, that's what the virus wants, so that its little mutants can infect people who are partially immune and further evolve that spike protein so that it can continue to overcome natural immunity. So you're familiar with the data in the adults. There were 3 pivotal trials that were done. Among the largest clinical trials done really in adults, but maybe for us since rotavirus. And there were 3 different studies. One was the Pfizer BioNTech, the Moderna, and the Janssen. And each of these was published in the New England Journal. And you can see here the Kaplan-Meier curve, days after dose 1 here, days since randomization or days since administration, and the cases that occurred in vaccinees and placebo recipients. This was incontrovertible evidence of efficacy in the context of clinical trials. Now, the thing is that it's not only not as feasible at this point in the pandemic like it was over a year ago when we did the adult trials, not only feasibility, but also necessity. There really isn't much of a reason to do a full-fledged efficacy trial where the endpoint is, did I get COVID or did I not get COVID? Because we can use a concept called immunobridging. And that's where, if we know the immune response that is protective in the adults, and we can demonstrate a comparable immune response in children, then we can make the assumption that those children ought to be as protected as the adults were. And you're familiar with this because we used this when the Tdap vaccine was developed, for example. Never had a study that showed that Tdap actually prevented pertussis in children, but we knew that it produced antibody levels that were similar to the DTaP studies. We were very privileged to be a site in the the phase 2/3 Pfizer study in children from 6 months of age up to 11 years of age. The cohort for which data have now been presented is the 5 to 11-year-olds. This map shows you the 4 countries that were involved in this study, and there were 55 sites in the US, and we were one of them. I just want to say a couple of things about this. Number one, I hope everybody recognizes that we have a Class A state-of-the-art clinical research unit at Norton Children's and University of Louisville, or now Norton Children's Research Institute. These folks have really gone above and beyond to make this trial happen here and for us to get kids enrolled and to be part of this history-making study. The other thing I would say is it's really refreshed my, revitalized my faith in humanity, because the interest from the community has been tremendous. Within a week or 2 of launching the study's website, which was publicly available, where people from the community could log on and register their kids in the study, we had over 1,400 families who volunteered to be in the study. And as it is, I wish we could have enrolled all of them, but we enrolled about 91 or 92. The other thing is the kids, right? They have been such troopers, and they have been so brave and so enthusiastic. They're real pictures, but these are actual real quotes from the kids in the study. I asked all of them why you volunteer for this study. I had one little girl say, because I want to save lives. I had an older boy say, because he wanted a Nerf gun. Apparently his parents promised him a Nerf gun as he was going to be in the study. I also tried to give the kids a sense of history that, for me, this was very much like the polio pioneers of the 1950s who volunteered to be in the Salk trials that showed that the polio vaccine worked. And I told one little girl that, and her response was, well, whatever. So there you go. This was a drawing by one of our study subjects where she was explaining to her younger brother what the randomization scheme was. 2/3 get vaccine, 1/3 don't get it. And that actually made it to the cover of the Journal of the Pediatric Infectious Diseases Society. And this picture hangs on my door, which is one of our kids drew a picture of COVID, which, by the way, was drawn freehand. So this kid's going to become an artist. So the vaccine is an mRNA vaccine that encodes the ancestral spike protein. That is the spike protein that has the Wuhan sequence. That's important to keep in mind because, as I pointed out, we've had at least 3 major evolutions since then. But I'm going to show you data that suggests that despite being made of the Wuhan spike, this vaccine is able to protect against even the Delta strain. And that's probably because the immune response is so robust that there's lots of promiscuity in the antibody response, lots of antibody made that's potentially going to knock off many different variants. The spike protein is pre-fusion stabilized by a 2-proline substitution in the cleavage domain. So the reason that had to be done was because the spike protein gets cleaved in order to allow for infectivity. And once it's cleaved, that little receptor binding domain is no longer as accessible, and you don't generate as good antibody to the post-fusion molecule. They also had to make some modifications in the RNA molecule to make it more stable, because there are RNases everywhere in the environment that could destroy that messenger. And then part of the strategy was to package it in this little lipid nanoparticle that protects it and helps it get into the cells. The dose is 10 micrograms. The dose you all got was 30 micrograms. And this came from a phase 1 study that compared 3, 10, and 30 micrograms. And it turned out that 10 was just as immunogenic and less reactogenic. And then it's important also to point out that this pediatric product not only differs by dose, but it also differs in the buffer. And so it is not exactly the same as the adult version. So the data that were presented to VRBPAC involved 2,250 kids, 1,500 of whom got the vaccine, and then another 2,250 who were enrolled in a safety extension of the original trial. And the strategy here was to compare the immune response in the kids to the immune response in 16 to 25-year-olds from another study where efficacy was already demonstrated. And as I mentioned, they also looked at the Delta variant, and they did do a descriptive efficacy analysis. Not that the study was powered to look at efficacy, but we did have data on COVID illness in the kids. Whenever they got sick, they did a nasal swab. So first, to talk about reactogenicity, this is here dose 1 and dose 2. These are redness, swelling, and pain at the injection site. Shown here are the kids who got either the vaccine or the placebo. And then next to them are the adults who got their vaccine or placebo. So first glance, you can see that the reactogenicity is similar between the kids and the adults. The second thing you can see is that the big issue is the pain at the injection site, which was higher, almost 75% in the vaccine recipients compared to the placebo recipients. These are systemic adverse events after dose 1. And you can see here that fatigue and headache seem to predominate. The other thing I do want to point out, though, on the prior slide and on this slide, is that it's the gray part of the columns that indicates severe reaction, severe fatigue, severe headache. And those slices of the column are so small you can't even see them. So lots of people, lots of kids get fatigue and headache. Most of that's mild, some is moderate, but very little of it is severe. And then this is here after dose 2. And you can appreciate, much like all of us kind of felt after we got vaccinated, is that the fatigue and headache may be a little higher after dose 2 compared to dose 1. So here are the adverse events, and this is after dose 1 through September 6th of this year. And this is for the initial cohort of 2,250 kids. Important to point out that severe adverse or serious adverse events were extremely unlikely to occur, and the ones that did occur were not related to the vaccine. There was one in the vaccine group that had a broken arm, and there was a kid in the placebo group who had pancreatitis, but that was after an abdominal injury. There were also no deaths in the study. Also, there were no cases of anaphylaxis or anaphylactoid reaction. There were no cases of myocarditis, no cases of severe COVID. That was a concern early on, which, if you remember back to the old data on the RSV vaccines, where there was an enhancement of disease by a killed RSV vaccine. That has not been seen at all with this COVID vaccine. And there were no cases of MIS-C. There were a few cases of lymphadenopathy in the vaccinees compared to very few cases in the placebos, which is a word, by the way, I just made up. And here, continuing with adverse events, this is in the safety expansion cohort, and you can see that the adverse events here were very similar, no life-threatening, very few severe, and no deaths. So here are the immunogenicity data. I'm going to show them to you in several different endpoints. This endpoint shown here is the geometric mean neutralizing titer of antibody. It's the amount of antibody that will neutralize 50% of the virus. So the scale on the y-axis is a logarithmic scale. Here are the vaccine recipients, and on the right here are the placebo recipients. The kids versus the adults, and the blue is before dose 1, and the orange is 1 month after dose 2. So you can see here that most people did not have antibody before they got vaccinated. After they got vaccinated, they had a large increase in antibody, over a GMT of over 1,000. And the response in the kids was almost identical to the response in the adults. And of course, the people who got placebo did not have measurable neutralizing titers. The second endpoint was geometric mean fold rise in neutralizing titer. So that is the question of, to what extent did your GMT go up after vaccination? And again here, for the kids, it was somewhere around almost 120-fold increase in neutralization, and that compared very favorably. It was not inferior to the GMFR that the adults experienced, and again, the placebo recipients, of course, were negative. And the third endpoint was the response rate. So this is the percentage of vaccinees who went from, I don't have any neutralizing antibody, to I now have 4 times the detectable lower limit of neutralizing antibody, or I had a little bit of neutralizing antibody and now I have 4-fold or higher amounts of antibody after vaccination. And you can see here that almost 100% of both children and adults had an adequate response to vaccination. And then there were about 34 kids who were studied who where their sera after vaccination was put up against the Delta variant. And you can see here that the GMTs were around 400, and there was not non-inferiority demonstrated between, oh, no, I'm sorry, that wasn't simultaneously studied with the adults. What was studied here is the reference virus, okay? And here is the Delta variant. And you can see that the GMT against the reference and the Delta are almost the same. So the vaccine is presented as a 10 microgram dose. I mentioned the change in the buffer compared to the adult. Now, the vials are orange compared to purple. There is a gray vial that is not made available yet in the US, but just so you know, that gray vial will exist. So the dose I want to point out in the kids is 0.2 mLs. We all got 0.3 mLs. This is a 0.2 ml dose. Comes in a 10 dose vial. The vaccine can be stored for 6 months in the super cold freezers, but at regular refrigerator temperature, it can be stored for 10 weeks. Once you have entered the vial, you need to use the vaccine in that vial within 12 hours. So the ACIP just met the last couple of days, and here are their recommendations, which haven't yet been published. You should get the age-appropriate vaccine formulation regardless of your weight or size. That means if today you are 11 years and 364 days old, you get the 10 mics. If you are 12 years or older, you get the 30 micrograms. The dosage is based on the age on the day of vaccination. The vaccine is now universally recommended for all persons 5 or older. And if a person has acute COVID, it's recommended to defer vaccination until they recover from the acute illness and until they are released from isolation. And yes, Chris, that is isolation, not quarantine. I've learned something from Chris Bryant over all these years. It is not recommended to do serologic testing in order to determine who should be vaccinated. And you should vaccinate regardless of I had COVID or I didn't have COVID or I'm antibody positive or I'm not antibody positive. And the rationale for that is that we have safety data from all the clinical trials that show it doesn't matter if you had COVID, you can still be safely vaccinated. We do know that the immunity from natural infection will wane, so we want you to be vaccinated. People respond differently to vaccines, I mean to natural infection, and so we want everyone to have the benefit of vaccine-induced immunity. And there's actually an advantage to vaccinating if you had the infection, because now you exploit the memory and anamnestic response, and you get a very robust immune response. In kids who've had MIS-C, that 6,000 of them or whatever, the benefits of vaccinating outweigh the risks. But you do want to wait until they've clinically recovered, and that includes back to normal cardiac function. We want to wait 90 days or more since their diagnosis. And by the way, it reads as 90 days since diagnosis, not 90 days since cardiology and rheumatology and ID release you. Definitely want to consider it strongly when there's a high community transmission rate. And want to be careful if there was MIS-C onset before any COVID vaccination. The other considerations are people may have personal risks of severe complications of COVID, and we want to weigh that into the decision, and also the timing of immunomodulatory therapies. So, if a kid was MIS-C and he got 2 doses of IVIG and course of anakinra and high-dose steroids and was on a long taper of steroids, we may want to mitigate that, we may think about that 90 days from onset. We may want to go a little bit later, and you can always call us to answer those questions. You can administer this vaccine without regard of timing to any other vaccines. I saw Pat Hines had a chat question about LAIV, you can give them on the same day, you can give them 2 days apart, whatever you want to do. And again, the formulations are not interchangeable. And I want to end so we can entertain your questions with this slide from the ACIP meeting. This shows the estimated benefits for every million kids who are vaccinated, 5 to 11 years of age. It's broken up into boys and girls. But for every million boys who are vaccinated, there will be 57,000 cases prevented, 226 hospitalizations, 130 MIS-C cases prevented, and 72 ICU admissions prevented. You know, one other thing I just want to say about safety, getting a lot of questions about safety. And what I try to tell people is that this vaccine is the most extensively studied vaccine we have ever had before we put it into kids. There's never been a vaccine. Do you know there are almost 3 billion people on the planet who have been vaccinated against COVID, and probably 2 billion of them have had an mRNA vaccine. And there are safety systems in place to pick up whatever rare side effect might have occurred after all those vaccinations. And so far, there have been some signals of some very rare things like myocarditis. But really, this is a extremely well-studied vaccine. And I think it's very safe. The clinical trials show that. The post-approval studies show that. And I think the benefits far outweigh the risks in vaccinating all the kids. So that's all the formal comments I have. And I guess, Chris, turn it back to you.
Hey, Gary, thanks so much. That was terrific. I will not bring up what I have taught you. I hope hope you weren't saying that was the only thing.
No.
Isolation versus quarantine. Okay, on with the show. So, you know, you mentioned that, you know, topics about which you've been getting a lot of questions. I think that one of the most common questions I have received is, can I not just give a third of the adult dose? Because, right, they get 10 micrograms. So I think that's important to emphasize. Do you just want to emphasize that?
Right. No, you cannot do that. 1/3 of an adult dose was not studied. The formulation that was studied is specifically this orange cap formulation. And so you just can't do that.
Okay, thank you. Now, you know what to do if a child turns 12 in between dose 1 and dose 2. The ACIP and CDC have now spoken. Now, some of the early, what we thought it was going to say is different. So I want to emphasize that because we may have talked about a different plan early on, but you get the dose for whatever age you are at the time. So when you are 11, you get the 10 micrograms. If you turn 12, then you get the teenager adult dose. But Gary, what happens if somebody doesn't realize the kid has actually turned 12 and the second dose is administered as a 10? What do you do then?
Well, first I have to tell you I'm smiling because the question, like, okay, well, what if you're 11, then you turn 12? It reminds me of a classic George Carlin routine where, you know, growing up as a Catholic kid, he had all these questions about confession. You're supposed to confess on Sunday, but, you know, he'd ask the priest, well, what if you're on a ship and you're in the ocean and you cross the international date line and it's not Sunday anymore? You know, would God forgive you? So anyway, it's the same sort of question. So if you are 12 or older and you receive the 10 mics because it's your second 10 mic dose, because you got the 10 before, now you're finishing it with 10, that's good. And it doesn't need to be reported as a mistake. On the other hand, if you're 12 and you're getting your first dose and it's 10, that is a mistake. So that should be immediately repeated with an adult 30 microgram dose. Does that answer the question?
Yes, I think so. That's terrific. We've had a couple of operational questions, and Pat Hines wanted to clarify that his question is about who can reconstitute the COVID-19 vaccine, because it does require reconstitution. Can it be a properly trained and supervised MA? I actually reached out to our practice manager, Amber McIntosh, who replied yes. In the NCMG offices, MAs are reconstituting vaccine. At the Norton-sponsored vaccine clinics, we've just chosen to use RNs. So hopefully that answers Dr. Hines' question. There have been a couple of questions about enrollment in the clinical trial, Gary. So are we still enrolling kids under 5, or is enrollment closed? And when do we think that we're going to have the under 5 data?
So great questions. At this point, we're not seeking new enrollees. I have to point out that there's a new arm to the study, which is a troponin arm. I told you there's no cases of myocarditis in the study, but we want to be really conservative about this. So this arm of the study is going to look for chemical myocarditis, troponin leak that might or might not occur after vaccination. And we are not actually participating in that part of the study. As far as when the data will be available for the younger kids, I should think by the first quarter of 2022, the data will be available. As you can imagine, it's been harder to recruit in the 2 to 4, and then harder to recruit in the 6 months to 2 years. So the cases have accrued more slowly. But I would think by first quarter, we'll have the 2, 3, and 4-year-olds. And then hopefully by the end of 2022, the 6 months to up to 2 years.
All right, so fingers crossed. We have another clinical trial question. So given that 10 micrograms is effective in kids 5 to 11, do you foresee any additional studies in older children and adults to see if maybe we could give less antigenic load?
Good question, because what you're doing there is we're really balancing immune response and reactogenicity, right? So before the 30 microgram doses were studied, there were dose ranging studies, and those were, of course, in the adults. And those showed that trade-off, that balance was right at 30 micrograms. There were dose ranging studies in the adolescents too, as also. I'm not familiar with the data, but I'm just assuming that 30 was chosen, 12 to 16 for that reason. So I'm not aware right now if there are that type of dose ranging study for the 12 to 16-year-olds. I guess I would ask the pediatricians in the audience this question. Really, do we care? I mean, okay, I'm just saying, right? Reactogenicity, we don't want to turn people off from the vaccine, but in some ways you just have to suck it up, because you don't get a good immune response without some inflammation. And I just haven't heard that reactogenicity has been a barrier for the teenagers. And if you have that experience, or if any of you out there feel like that is a big part of this, I'd like to understand that better, because I don't know, I think the teenagers, it's more just, I don't want to go get a shot, but.
Yeah, you know what, how about, friends, why don't you type that in the chat? If concern over side effects is a barrier that you have seen in your practice, type it in the chat, and I'll try to come back and summarize. So Gary, there is a question, I guess, about anticipating side effects. Do you recommend giving a pain reliever such as Tylenol or Advil 30 minutes prior to kids getting the vaccine?
I don't think you should do that, because there's some controversy about this. There was a study a number of years ago that suggested that NSAIDs given prior to a dose of vaccine not COVID, but other vaccines might limit the immune response. And it would make sense because you need that innate immune system to be turned on in order to get an adaptive immune response. But then there were later studies that refuted that. I think CDC's party line position is don't pre-medicate, but if you develop, intolerable symptoms in the hours after vaccination, go ahead and take whatever anti-inflammatory or Tylenol that you want to take. Chris, that's pretty much what the party line is, right?
Yeah, that's my understanding as well. So parents, there have been a number of surveys asking parents about their concerns. And I think for parents who are on the fence or are in the not ready to vaccinate camp, they have concerns about safety. So that we have a couple of safety related questions. One, what do we know about long-term effects of the vaccine on children? And there's a question that I think is kind of hard. Has tinnitus been seen as a vaccine side effect in pediatrics? I don't know the answer to that one.
I don't know of any cases in pediatrics, but it has been seen in adults, and very famously was seen in Greg Poland, who is at Mayo Clinic, and he's the editor of the journal Vaccine. And he wrote about this, and he's convinced that his case of tinnitus did occur because of vaccination. It's resolved. But I haven't heard about that in the children. In terms of long-term safety, so here's the thing. We almost never have data on long-term safety when a vaccine is initially released and recommended. We take our chances on this because we know historically there really isn't a vaccine that has some unforeseen long-term side effect that comes to light decades later. I mean, literally, there is no example of that I know of. And so I'm comforted that we have centuries of experience with vaccination, and we really don't have any evidence of these types of long-term side effects. That being said, in our study, we're following these kids for a couple of years, and the safety programs in the country, the pharmacovigilance programs, the VAERS, and the Vaccine Safety Data Link, all look for these things. And so far, there's no long-term thing, quote, long-term, that has popped up. We're only not even a year into the vaccination era.
But we wouldn't anticipate long-term side effects because vaccines, if they cause side effects, you tend to see those in the first 6 weeks, right?
Really in the first 3 days.
So there are a couple of comments in the chat about fertility issues after vaccination. Maybe it would just be helpful for the group when you get that question, what do you say to parents?
Okay, first, where did this come from? It was a blog post from a person who looked at the amino acid sequence of the spike protein and of a protein called syncytin 1, which is a placental protein that actually probably derives from some ancient virus, and found some amino acid similarities, literally amounting to 3 or 4 amino acids in the same position, which does not constitute homology in the broad scheme of things. But this person hypothesized that if there is homology between spike protein and syncytin 1, maybe you make antibodies then to your own placenta, and that affects fertility, et cetera. There's absolutely no clinical evidence of this whatsoever. And even if it were true, getting COVID is probably worse than getting the vaccine, because you would expect the same effect from being infected with COVID, and there's no evidence even having had COVID that you are somehow then infertile. So I sound like I'm being the soup Nazi here, but it's not true. It doesn't make you infertile.
So it helps me to hear what you say and your narrative. to parents, because it helps me refine my narrative and like make a note and say, oh yeah, I don't say that. Maybe I'll make that point as well. There have been a couple of questions about myocarditis, because, you know, parents have heard about this and they raise this concern. So what's your narrative about myocarditis? You showed us the data, but tell us what you say.
Okay, so first of all, it's a real relationship from everything we can tell. Second, the relationship has only been established in adolescent males. Third, the risk, and by the way, puberty is a time when we begin to see more myocarditis just in the background. So maybe there's something about puberty and, you know, being a teenager. Third, the background rate of myocarditis is somewhere around 20 per 100,000. And so when you have a rare side effect related to vaccine, it's hard to detect that above the background rate. The best estimate of how often this occurs is about 1 in 15,000 for adolescent males. And as I mentioned, we've not seen it in the young kids. All of the myocarditis that has occurred has been mild. I think there are a few case reports of adults who died with myocarditis, but it's not clear exactly what that was. And the cases that have been in the kids have been very mild. Some chest pain goes away with ibuprofen or naproxen. Don't really know what the causal relationship is. I have to wonder if there are not kids out there who are destined to get myocardial inflammation if they experience a certain trigger. It might be an enteroviral infection, it might be an adenoviral infection, it might be a COVID vaccine, and then maybe that somehow brings them, you know, out of the background. We'll know that because you would expect then there might be a compensatory decrease in myocarditis among vaccinated people later, you know. But that's what I tell them. I don't worry about it. A lot of parents in the trial asked that question, and that's how I answered it.
Thank you. That's really helpful. I hope that's helpful to our audience as well. There are a couple of just operational vaccine questions. So questions from pediatricians about how are we going to do this in our offices? We're already really busy. Are we going to have enough vaccine? When people log on to nortonchildrens.com and look for a vaccine appointment, sometimes they may look full. So here's what I understand from Craig Johnson. So for the offices, my understanding is that for pediatricians who are within NCMG and family medicine providers who are within NCMG, you already have vaccine appointments. And so this will not be a free-for-all. Patients who want a COVID-19 vaccine appointment will choose vaccine appointment. Soon, they will be able to schedule this online. If the demand exceeds the supply, then that is absolutely something that you can talk to your practice manager about, your operations person. We are also giving vaccine at our community vaccination sites, including the one at St. Matthew's and the one on Broadway. So that's what we're doing now. People are constantly monitoring the demand. And so if all the slots are filled up, there's the potential to add more. There was a question about, are we going to have enough vaccine? Yes, we anticipate having plenty of vaccine. We'll be immunizing kids from across the community at those sites if their pediatricians don't yet have vaccine in. As some of you know, we are giving vaccine at hospital discharge to eligible children. We started that with 12 and above. We'll move to immunize younger children as well.
Chris, there's a question from Jamie Furlong-Dillard about the data that were presented on the clinical trials. That was across the whole clinical trial, all sites around the world.
Yeah, thank you for clarifying that. There was also a question about, I think, leukemia, lymphoma as a after vaccine.
Well, that's a new one to me. I mean, I heard about being tracked by the CIA, and I've heard about your arm becoming magnetic after you get the vaccine, but I have not heard about hematologic malignancies.
Yep, thank you. So there's a question about the number of children over 12 who've been immunized. And the questioner says, I remain concerned that the acceptance rate in many families is not where we want it to be. I share that concern. I think nationally, we're at just about half of eligible 12 and above, and Kentucky is not in the top half of states. So Gary, practical strategies about what we need to do to get that rate up and make sure that our acceptance rates in the 5 and above is better?
So I have to frame this in the broader context of your of immunization policy, immunization recommendations, and what it means to be a parent, right? So, you know, we talk a lot about parents' rights, and families have the right to not get vaccinated if they don't want to, and that sort of thing. But what the law really concerns itself with, and what we should be concerned about, is parental duty. You know, it's fine if you're an adult and you don't want to be vaccinated, take your chances on COVID, or unless you don't want to lose your job, you know, because it's mandated. But you don't have a right to put your kids at risk. And your kids aren't enfranchised and they can't make their own choice. And I just think we need to frame it not in those, you know, soup Nazi terms, but in terms of, you know, look, I understand you want to be cautious, and I understand you don't want to do anything to harm your child. But I can just about promise you here, now I say just about because nothing is 100%, right? But I can just about promise you that the harm that would come to your child from COVID, or the harm that would come to grandma from your child getting COVID, far outweighs any harm that they will get from this vaccine. And that's just, I think, how we have to frame it for them. And tell them to, if your kids got the vaccine, because I know they did.
That's a great point. Yeah, a member of our community reached out within the last week to talk to me about a teenager who had persistent symptoms after COVID infection. And this was a really heartbreaking story. The child was the first in the family to get COVID, was unimmunized, brought it home. Everybody in the family ultimately got infected, and a grandparent ultimately died. So really heartbreaking. So time for a quick speculation question, and then I'll wrap up with some operational notes. Do you anticipate a yearly flu COVID combo in the future?
Not in the near future. I think first we're going to have to establish what is the persistence of immunity following pediatric vaccination. Are we going to need a booster in these kids in 6 months? Then we'll need to figure out to what degree does this become endemic, and is one shot when you're a young kid good enough, or do you have to be vaccinated seasonally, yearly? And then they'll worry about putting it all together.
Yep. Great, thank you. So to sum up, this is a 2-dose series. We had a question about that. 2 doses, 3 weeks apart. And yes, you are immunized with the dose for whatever age you are at the time. Yes, we talked about something different last week, which is the downside of trying to share behind scenes information before CDC ultimately decides. So what CDC decided is if you get your first dose at age 11, you get 10 micrograms. If you turn 12 over the next 3 weeks, you'll get a 30 microgram dose. And if you inadvertently get 10 the second time and you got 10 the first time, it's fine. You don't need to repeat it, and it's not considered a vaccine error. Can
I just add one other thing? I personally would not defer vaccination in the 11 years, 9-month-old. I would not wait so they can get the 30, because the 10 works. And I wouldn't want 3 more months of susceptibility to COVID.
So if your child is 5 and above and eligible now, get them the vaccine. Well, Gary, I see we are right at the top of the hour. Thank you so much for sharing this information, sharing your perspective and your vaccine narrative. I found that incredibly helpful. To the audience, thank you for joining us today. If we have a few unanswered questions, maybe we can try to do those, do a summary by email, but it is great that so many people turned out today. And